Uh, Sir, good evening, sir.
Good evening.
Sir, Arun from Railway, sir.
Yeah, go ahead.
I couldn't get the video, sir. I'll start the presentation, sir.
Yeah, no problem.
Okay, sir. It's a 25-year-old male, a chemical factory worker in ICF unit, has come with chief complaints of excessive post-burn scarring of lower chin, anterior neck, right upper arm for the past 18 months, associated with decreased neck movements, with inability to look upward, and also associated with limited mouth opening. History of presenting illness, apparently normal prior to the fire explosion 18 months ago, following which he has developed this burns, which involves the lower part of the chin, neck, anterior neck, as well as the right upper arm. Was managed in ICU for first 2 days, later in the burns unit, and finally got discharged after 8th day. Twice he underwent burns dressing under total intravenous anesthesia. Gradual scar tissue formation with decreased neck movements and mouth opening was associated. There was an associated history of weight loss up to 6 kgs over the past 3 to 4 months. No history of stridor, soot in the sputum, respiratory distress at the time of sustaining burns injury. There is no associated voice change, dysphagia or aspiration at the time of burn injury. There is no history of airway intervention at the time of sustaining burn injury, or either interventional procedures like tracheostomy in the later part of the treatment. Past history, there was no other comorbid illness like diabetes mellitus, systemic hypertension, bronchial asthma, TB, epilepsy, or any other psychiatric issues. Personal history, mixed diet, is a known ex-smoker for stopped 5 years back prior to the event, 1 pack per day. No other addictions, no history of drug allergy, no other history of drug intake. Normal bowel and bladder habits. Sleep pattern is normal. Usually he sleeps in the lateral position with a pillow under his neck. Family history, not relevant. Treatment history, no other relevant medical history or surgical history in the past apart from the burns dressing under anesthesia. General and physical examination. Patient is conscious, oriented to time, place and person, comfortably sitting with no signs of respiratory distress. He's thin built, averagely nourished. Weight is 50 kilos. Height is 165 centimeter with a BMI of approximately 18.5. There is no signs of pallor, icterus, clubbing, lymphadenopathy or pedal edema. Peripheral veins are quite accessible. Vitals, BP, blood pressure 120 by 70, left upper arm in the sitting position, pulse rate 70 per minute, right radial in rhythm, moderate volume, no radiofemoral delay. All the peripheral pulses are felt and normal. Respiratory rate 14 per minute. Saturation, SpO2 saturation is 96% in room air. Airway examination, mouth opening, 2 finger breath or 3 centimeter. Malampati grade 4. No loose tooth or missing teeth. Spiromental distance could not be measured. Sternomental distance 8 centimeter. Unable to protrude the mandible. Temporomandibular joint can't be insinuated.
One second, Arun, hold on for a
minute. Yes, sir.
Second.
Yes, sir.
Nama? ஓகேம்மா. இது ஏற்கனவே சைன் போட்டிருக்கேன். இன்னும் இது போதுமா, இது பேரை போடணுமா? உங்க பேர் என்னம்மா?
அஞ்சலி சார்.
அஞ்சலி ராஜனா? Thank you very much. Thank you. Yes, Arun, carry on.
Yes, sir. Airway examination, mouth opening, 2-finger breath or 3 centimeter, Mallampati grade 4, no loose or missing teeth, thyromental distance can't be measured, unable to protrude the mandible, temporomandibular joint, can't insinuate one finger in front of the tragus, neck movements severely restricted, nostrils bilaterally patent. Local examination, burn scar over the lower chin, front of the front of the neck, upper chest, and right arm. Circumferential scar involving 50% of the anterior part of the neck, and 3 strong visible bands seen in the starting from mentum to the mammary region. There is no ulcers, scars, or fistulas. Thyroid, cricoid, and cricothyroid membrane trachea are not visible externally. Palpation, the scars are non-tender, firm, and raised. Sternal notch is palpable. Carotids are well felt. Cricothyroid membrane, trachea, and thyroid are not being palpated. Moving on to the systemic examination. Overall cardiovascular system, both heart sounds heard, no murmurs. Respiratory system, normal vesicular breath sounds heard, and clear lung fills. Abdominal examination, it's soft, no organomegaly. Central nervous system, there is no focal neurological deficits.
So other systems are clinically normal. Okay.
Normal.
To sum up your...
Finally, I can summarize, sir. So it's a 25-year-old male patient with post-burns contracture over chin, anterior part of the neck, right upper arm for the past 18 months of duration with a difficult airway of Mallampati grade 4, scheduled for elective contracture release and splits SSG under general anesthesia.
Okay. Now, some points are missing in your final sum up. Can you recall and say what are all the points you are missing and some extra points you have added? So, if it is like a case presentation, what are the points you have missed and what are the points you have added in this? Now, you have not mentioned about the etiology or cause of the burn, whether it is chemical burn, whether it is flame burn.
Mentioned, sir.
No. Here in your final sum up, you just said it's a post-burn contracture, isn't it?
Fine, sir. Yes, sir. Correct, sir.
Right. So, initially you said it's a factory chemical blast or something, isn't it? So,
yes, sir.
That should come in the end also. Etiology of the burn should be, because electrical burns, what is the difference between each type of burn etiology? What is the difference in dry heat? What is the difference in wet heat or scalds? What is the difference in a chemical burn? What is the difference in an electrical burn? Do they behave differently or do they all of them behave in the same way?
Each has their own characters, sir. For example, the electrical injury depends whether it's a high voltage, a low voltage injury.
Okay.
There will be an entry and an exit. Wound will be there, and in between during that path, any vital organs can be affected.
Very good.
With regards to the chemical injury, the scarring and all those things are very common due to the excessive fibrosis and all those things, sir.
Anything healing by secondary intention will have severe fibrosis. That is not a problem at all. But the chemical injuries, the
airway involvement of chances of airway.
Healing takes a long time. Compared to the flame burns or the scalds, the healing takes a long time because of the surrounding areas of the normal tissue around the burns also get affected by that. So the formation of or epithelialization takes much more longer time compared to the other types of healing. Okay, so that you have to include. And then second, you said it's a difficult airway. Anticipated difficult airway is your problem in giving anesthesia. Okay, but you have to say what degree of contracture is present. That has never been mentioned in your description. Because unless you know how to classify the post-burn contracture, especially of the neck, what are the ways to classify the neck contracture, then only the degree of difficulty will come accordingly. Okay, so how do you classify the contracture?
Depending upon the neck movements, it's classified into mild, moderate, and severe.
Severe, very good. Then, based on the shape, can you classify them? The shape of the contracture or the configuration of the contracture. It can be classified into linear contracture, band contracture, and broad contracture. Now you said there are 3 bands, which may be probably a formation of a wide contracture in front of the neck. So you have to call them as broad contracture rather than band contracture. Even though they appear to be like 3 bands, it is a continuation with intermediate projection. In between, if you have a normal skin, you can call them as a band contracture. But in between the bands, if the skin is also contracted with a fibrosis, then you have to call it as a band contracture. So why this shape of the contracture is important for us? For example, you have a person with a, say, a contracture like a small band running from the chin to the mentum. Only one single band is there. Or
under local infiltration.
That can be managed with local methods of infiltration.
And you can convert the difficult airway into a slightly a better one.
No, you need not. You need not worry about giving GA at all. If it is a single band, the surgeon will manage it under local infiltration with what is called the Z-plasty or Z-plasty. They can expand that contracture and the scar and expand it so that nice release can be obtained by what is called Z-plasty, which can be done under local infiltration anesthesia. So it won't be a headache for you. On the contrary, if you have multiple band-like contractures, all of them cannot be released by this infiltration and Z-plasty. That may require, so there are 2 methods, incision and release and excision and release. Okay, the treatment for post-bone scar contracture according to the plastic surgeons are classified into 2 ways. One is just an incision and release and put a small graft, or excise the whole scar tissue, create a big raw area, then apply either a skin graft or a free flap or a rotation flap from the neighborhood, that depending upon the nature of the release and the extent of release. Okay, too large area, you cannot harvest such a big flap. Then you have to go only for a split skin grafting. Whereas a small area, to prevent future contracture, you can go for a free flap or a rotation flap from a neighboring, either a back or the shoulder. All these normal areas, you can raise a flap and put it over the dry area and cover it. Okay. So from the treatment or the surgical aspects, we have to know what will be what are the 3 types of description. So first one is the limitation of the movement. Patient not able to look up or able to look up to some extent, that is mild degree. Patient not able to look up, the angulation is restricted, that is 2nd degree. Patient is a permanent fixed flexion with the chin attached to the mentum, becomes 3rd degree or severe degree. That is one classification. The second classification is based on the scar, size and shape of the scar. So linear scar, band scar, broad scar. These are the 3 things. This is important for deciding what will be the type of treatment or surgery that can be performed on that. The third one is called if the scar is restricted only to the neck, then that is called a primary or a local scarring. If it is extending to the chin, lip, in your case, you said your lower lip is involved and it is extending onto the right shoulder, chest and all these things, that is secondary or extensive scarring. Okay, so that is also another way of classifying. So the dissection will be more, the requirement of excision of the scar tissue will be more. So there the blood loss can be more. So you have to be prepared for all those things. So these three types of classification are there for the post-burn scar. So you have to describe in your description all the three and give your final diagnosis that this is a post-chemical burn scar contracture occurring over the front of the neck, including from mentum to the sternal suprasternal notch, which is a mild or moderate type of scar, linear or band or broad type of scar with its primary or secondary involvement of the neighboring tissue. All the three should be described in your final description or summation of your scar. And now you can say that patient is posted for either excision of the scar and skin grafting or excision and free flap, whatever they have planned. So patient, primarily it is for release of the neck contracture. Whatever surgical plan you need not include in your final sum up. You need not say, they may say release of scar contracture and planning according to whatever mode of treatment, whether grafting or whether free flap or whether sometimes they may use what is called a tissue expander also to expand the neighboring skin and then lift it up and then bring it into the area and cover it up. So there are so many things. I will show you in the presentation all this type of treatment. So the treatment you need not say, the patient is now referred to you for release of the post-burn contracture. That's all. Okay. So now what are the challenges you are going to face in this case? He is a young man, 25 years old. He has suffered this. He has successfully come out. What was the original percentage of burn when he suffered? Also, you have to mention because you said percentage
No,
and
I
depth
haven't
of
mentioned
burn.
about, sir.
Yeah, you have to mention that also because you are describing how the accident happened and you said whether there were associated respiratory burns were present or not. All that point you have said, but the first thing you should include in that description is what was the total percentage at the time of this accident and what was the depth of the burns that happened, whether first degree, second degree or third degree. Okay. Which degree of burn will result in such a severe contracture?
Third degree burn, sir.
Only third degree or second? So what are the
involving the reticular dermis? Involving the reticular dermis, sir.
Reticular, right from reticular to deeper tissue. Okay. So what is the method or mechanism of healing of a burn injury? Whatever be the etiology, whether it is chemical or flame burns or scalds or electrical burn, what is the mechanism of healing? How does it heal depending upon the degree and depth of burn? How do you describe that? Supposing you develop first degree burn while you try to prepare coffee for you and you burn your hand or finger. You develop only a first degree burn. What will be the description or appearance of a first degree burn? How do you identify the depth by visualization, visual inspection? How do you identify the depth or the degree of the burn? Supposing your dorsum of the hand is burnt while you try to lift the hot pot from the gas stove and the flame for a momentary thing burns your dorsum of the hand and it is a first degree burn. How will you identify that it's a first degree burn? What will be the appearance?
It will be red, more of superficial.
Yeah, it will be like an erythema. Okay, ordinary redness with an erythema. Sometimes if it is such a steam, wet heat, supposing boiling water pours on your, you will, no, scald, but how will it appear? To make a diagnosis that it is called scalds. Okay, but how will it appear when the hot water pours on your skin? which is
associated with the blisters.
If it is associated with blister also, you can call it as first degree or second superficial. So there are actually 4 degrees, first, second, third, fourth, but second is again divided into second superficial and second deep. Okay?
And deep.
Right. So first degree burn and second superficial degree burn will heal by a process called restitution. That is, whatever tissue or cells that have been lost will be replaced by the same cells and they will grow back. For example, even your hair follicles will grow back if you develop only a first and second degree superficial burn. So because they are all restored to its original shape and original histological features, it is called restitution by healing. On the contrary, if the depth of the burn becomes more than deep second degree or third or fourth degree, tissues are totally lost and they cannot be replaced by the same type of cells. So there it will have to heal only by fibrous tissue formation because fibroblast will become active and this fibrous tissue is consisted of collagen. So this collagen and fibrous tissue only will have to replace all the necrotic tissue that have been killed by the burn heat. So that healing is called healing by substitution. The normal cells are substituted by fibrous or elastic or collagen tissue. So that is called healing by substitution. So the first degree and second degree superficial heal by restitution to get back the lost cells like pilosebaceous cells, hair follicles, sweat glands, everything will grow back. That skin will become normal like the skin which before it got burnt. Whereas beyond the second degree, deeper, third and fourth degree, it can never heal by or come back to the normal original shape. It has to heal only by substitution forming. And when the thing happens in an area like neck, which has a loose skin like this, the extent of burn will be so deep that they cannot be replaced by the same original skin. So when the fibrous tissue forms there, it starts shrinking. It cannot maintain the same elasticity of the normal skin. So it starts shrinking. When it starts shrinking, what will it do? It will start pulling the structures which are underneath, whether it is a muscle or tendon or a neurovascular bundle, or even sometimes growing bones also can be bent, or joints can be dislocated or subluxated. That much of force will be there in the fibrous tissue. So that is what will happen in the post-burn contracture, not only in the neck, but in the hands, in the forearm, in the knee, wherever you get a burn injury. When the healing takes place by substitution with the formation of fibrous tissue, the contracture will not only shorten that portion, but also it will contract the structures beneath that. And that will be a permanent disfigurement. That is why patient needs a surgical correction to re-establish the original length or the functionality by excising the scar and then healing that wound created or the raw area created by some other modes of treatment. Okay, so this is what you have to understand. So now in your case, you say the patient is not able to look up, isn't it?
Yes,
Looking
sir.
up is restricted and the lip is also
Mouth opening
mouth opening is restricted. When the mouth opening is restricted, you cannot describe Mallampati grade 4. So the test Mallampati grade 4 we do only in a patient who has a normal mouth opening where we can inspect the structures inside. When there is a mechanical restriction to the mouth opening by in the form of a pulling down of the jaw and then fixing it in one position, you should not describe Mallampati score in those cases. So that is a mistake commonly all the students do, describing Mallampati, because unless you are able to look into the mouth, you cannot, because Mallampati grade 4 is looking our ability to see only the hard palate. You can't see anything. And when the head is bent like this, how will you do? Because you are supposed to keep the head in a eye level of the patient. Both of you should be able to have the same angle, and patient should widely open the mouth without and protrude the tongue out. Then only you can do the Mallampati testing. So Mallampati testing will not hold good in a case of post-burn scar contracture. So you don't have to mention that at all, unless the scarring is very limited and patient has the normal mouth opening, then you can always describe the Mallampati score. But when it is a fixed flexion or third degree contracture, Mallampati score should not be described in that. Okay, right. And whether there is a restriction on the side to side movement is also very much important. In this sort of contractures of the neck, where the mentum is almost touching or it is fixed permanently to the suprasternal notch or the sternum, what should be the ideal method, or when will you call that as when the treatment is successful or ideal? How to assess the degree of release is ideal? What one particular angle has to be restored? Now you are touching your skin and you are looking up like this. When you look up, what angle is formed? Now you have a length here from your mentum to the hyoid bone, then from hyoid to your sternum, isn't it? In a normal neck, you have a normal distance from the chin to the hyoid bone, then from the hyoid bone to the sternum. So imagine two lines going like this, one line going like this, another line going like this. Okay. In the neutral position, they are like this. Okay. Are you able to see my hands? See this, that is representing the length of the mandible from chin to the hyoid bone. So imagine a straight line going like this. Then there is a second line from hyoid to the mentum. So they are meeting at an angle. What should be the normal angle? Now I am showing you the angle. See, this is the line of my chin to hyoid bone going like this. There is another line coming from the suprasternal notch towards the hyoid. So this is the shape of our normal head and neck. So how much is this angle? Is it almost looking like a right angle?
90.
It's almost by 90 to 100. Okay, that should be the normal angle. And what is the name for this angle? You are starting from the mentum and trying to mark an angle to the sternum. So join both and tell the angle.
Mentosternal angle.
Exactly. That is called sternomental or mentosternal angle. So your aim should be to recreate that mentosternal angle. Because once the contracture happens, the neck gets fixed like this. There is no angle at all. It becomes acute. The mentum, the chin gets fixed down like this. So even if you try to pass a line, the line comes like this and the sternal angle is like this. So this mentosternal angle becomes an acute angle less than 60, 70. Then it becomes a very difficult airway. Okay. So the ideal treatment should always restore this mentosternal angle, create this gap here underneath the chin. If the surgeon does not take out all the scar tissue from the submental area and then make that angle normally, patient will still have difficulty in moving the neck. So that is a very important point the surgeon should take care of. And that is the same point which gives you all the problem of maintaining or securing the airway. So mentosternal angle you should remember very well. So what are the, how do you proceed with this case? You said that patient has been referred to you for release of the contracture and then treatment with probably skin grafting. So how to manage this patient? What are all the challenges in this patient you face?
I'll first start investigating him, sir, by doing a complete blood count, including hemoglobin, TC count, platelet count, then renal function test, urea and creatinine, with serum electrolytes with sodium, potassium, and coagulation profile, including PT, APTT, and international normalized ratio INR, along with PT, CT, then blood trooping and typing, a routine electrocardiogram, ECG, and a chest X-ray.
Okay.
And if possible, X-ray neck in the lateral view.
Okay.
So these are the blood investigations that are.
What do you want to see in the X-ray neck lateral view? What is the purpose of taking that X-ray neck lateral view?
Just to see the tracheal shadow, sir, whether the continuity is there or not.
Okay, continuity will be there, otherwise how will the face?
Continuity will be there, sir. The angulation.
Any angulation or any restriction, okay? Why that is important? Why? What is the purpose of taking that lateral X-ray of the head and neck and finding out how the tracheal air shadow is distorted? What is the purpose?
Accordingly, in case of if we are planning for a awake fiber optic intubation, accordingly we can select a appropriate size tube, and also in case with the least possibility chances of doing a blind nasal also it helps in.
Very good. So that is a very important investigation which will tell you, because sometimes the epiglottis will be so angulated that even if you use a fiber optic and try to go, entering the glottis will be very, very difficult. So that can be assessed before the procedure is done by taking this X-ray. Any other angle you can form in that X-ray? In clinical examination, I told you about mentosternal angle. Is there any other angle that can be assessed in the head and neck lateral X-ray? That is also another angle which you have to draw and find out to assess the degree of the contracture. Okay, so just like what you do for mentosternal angle, there is another angle that can be calculated, is what is called maxillopharyngeal angle. Okay, so in the lateral X-ray of the head and neck, you draw a line on the maxilla just above the root of all the teeth in the maxilla, a straight line. Then you draw another line in front of the body of the cervical vertebra. These two will have to meet and make an angle of at least 110 degrees. This is only a normal position of the head. Just as I told you, about 80 to 90 degrees is the mentosternal angle. The maxillopharyngeal angle in the lateral view of the X-ray will make a 110 degree angle in a normal healthy person. When the neck is in a fixed flexion contracture, maxilla will be pulled down, and the front of the cervical vertebra are also distorted. So again, when you draw a line on the top of the maxilla, that is above the root of all the teeth in the maxilla, and another line in front of the body of the cervical vertebra, this angle will become very acute instead of 110 degrees, which is an obtuse angle. This again will give you a clue how difficult it may be to do even a awake fiber optic intubation also. So based on that, you have to adjust your position and your movement of the fiber optic scope so that you can enter the glottis without any difficulty. So that is the reason why you have to take this. Otherwise, being a 25-year-old person with no comorbidities, normally you expect all the other systems to function well. Do you have to do any electrolyte studies in this stage now that it is more than 1 year and 9 months? Do you need to have a basic electrolyte, especially potassium level? Is it required in this stage?
Not mandatory, sir.
Why?
Since being almost like 18 months.
So when supposing up to what time of post-burn healing you require the potassium value, and what is the significance of that?
Previously it was 180 days, sir. Right now they have come up to 120, I think so.
Listen to Dr. Gado's video. I don't know from which reference he gave all those points. I'm not sure about it, but
180 will be the standard
whatever it is, the textbooks still maintain, because all the textbooks still say from 48 hours post-burn injury up to 1 year is supposed to be the thing. All the other reductions, 180 days, 120, 210, 240, all these things may be appearing in journals, but in the exam, I think what you have to say is from the standard textbooks. So it is always safer to go for a longer period of avoiding hexamethonium to prevent unexpected hyperkalemia, which can happen. Okay. Okay. Right. So how are you going to manage this case now that all the investigations have been done and you know that it is going to be an anticipated difficult airway? What are the challenges that you are going to face in the management of this case?
Sir, I think Dr. Aromal will be taking over that one, sir. He has started.
Okay. So your work is over to present only. Okay.
So good evening, sir.
Good evening. Can you show your face, Dr. Aromal? Where are you from?
Sir, I'm from Kerala, sir.
Kerala. Which college you
Sir,
are?
I'm right now Sri Balaji Medical College, sir.
Krompet, Chennai.
Yes, sir.
Okay. Your video is not working?
Sir, it should work, sir.
Okay. Right. Okay.
Sir, so first, like I'll be talking about the preparation of the patient, sir. Most of the patients with a postponed contracture will have a poor oral hygiene. So I'll try to improve the oral hygiene. And most of the patient will be anemic and malnourished. So I'll try to correct those things. And then some of the patient may have even a respiratory tract infection. So I'll try to correct those things, sir. Then the other common difficulty which we face in such patients are normally the positioning of the patient. So, due to the contracture, some patient may not be able to lie down properly, sir.
Very good.
Then other things are IV access. The deep scarring and all can make it difficult for IV access. Then even application of the monitors such as ECG, even pulse oximetry may find difficult, sir.
Very good.
Then other things, such patients may develop tolerance to opioids.
Very good.
Then within intraoperative period, sir, that what we have to suppose to manage is blood loss, hypothermia. So these are things, and some patient may even have psychological problems, behavioral problems.
Very good.
So
What
these are
sort of psychological problem will happen?
mostly depression, sir. Then
Post-traumatic stress disorder.
PTSD also, sir.
Very good. Excellent.
So these are the things. Then other than that, what are the common 4Ds which you're going to face is difficult mask ventilation, difficult laryngoscope intubation, difficult surgical access airway, and difficult even supraglottic airway device placement also. So these 4Ds which we'll face in these cases. So within the OT, there are certain things which I'm going to prepare. That is, I'll make sure that the ECG, BP monitoring. That too, I will go for IV, meaning invasive BP monitoring, sir. ETCO2, pulse oximetry, temperature monitoring, and urine output monitoring also, sir. Then I make sure the OT temperature should be in an ambient temperature that is around 28 to 32 degrees Celsius. Then other things which I'll make sure is that I'll keep a difficult airway cart ready, which includes all the resistant drugs as well as tracheostomy tube.
Okay.
And I'll make sure that the END backup is also there. So that
Very
in case, in case if I can't ventilate or intubate, I need access.
Very
These
good.
are things which I'll keep in mind. Then other things like pre-medication. So coming to pre-medication, maximum I'll try to avoid any heavy sedations and even narcotics also. Then to preserve the spontaneous respiration, sir. Then I use IM glycopyrrolate and atropine to reduce the secretions. And then I'll continue with the S2 receptor blockers as well as antiemetics, sir. So these things I'll be looking into. Then sometimes if the contracture is small, that is like if it is exposed from hyoid and up till only up till upper margin of the thyroid cartilage, I may use even superior laryngeal nerve blocks. Then so that you can try to prevent the laryngospasm. Then so these are the things which I look into. Then coming to the plans, there are 5 plans which I'll be looking into, sir. Plan of anesthesia. That is, one is so for if it is mild contracture, I may go for tumescent anesthesia. So tumescent anesthesia, there are 2 types of formulas, sir. One is the Klein formula and Hansard formula, sir, which I'm using. And mostly I'll prefer Hansard formula because usage of RL, which reduces the pain, sir. And then other techniques are tumescent with TIVA also, total intravenous anesthesia. That is like propofol with fentanyl or ketamine with fentanyl. Propofol around 9 to 15 mg per kg per hour. Then fentanyl around 1.5 to 2.5 nanogram per kg per hour, sir. So these are things which I will look into. For the plan B, sir, there is tumescent anesthesia with slow contracture release till I'll be able to see the cord, sir. Then try to intubate with either video laryngoscope or I'll insert this thing, sir, supraglottic airway device, sir. Then plan C, it's mainly using either ketamine or inhalation anesthesia and slow release of contracture. And the same things, sir, either intubate or use of supraglottic device, sir. Then other plan D is using awake video laryngoscopy, sir. So, but like in this situation, the counseling is a major important thing for awake patients. And so, I'll counsel the patient regarding what kind of procedure I'm going to do to relieve any anxiety related to it. Then I'll try to nebulize with the lignocaine. That 2 ml of 4% of lignocaine, sir. Then after that, then I'll spray with spray the oropharynx with the 10% lignocaine. Then I'll try to do the video laryngoscopy, sir, and try to. Then other one is awake FOB. So awake FOB, same thing. Try to counsel the patient regarding the procedure. Ask him to breathe properly. Then again the lignocaine nebulization, 2 ml of 4% and 10% lignocaine spray on the posterior pharyngeal wall. And I may use even nasal decongestion like xylometazoline. Then if I'm using FOB, sir, the spray as you go technique also I'll use, sir. Then try to intubate the patient, sir. So these are the main things that I'll be looking into. Then, then other intra-op management is blood loss, sir. Since the scarring is there, there will be some huge amount of blood loss, and it's very hard to estimate the blood loss. So, so invasive this thing. So we can take. We are supposed to take ABG, sir. ABG and get hematocrit values and try to replace with PRBC and FFP, sir. Then try to prevent the hypothermia prevention, sir. So warm fluids, warm blankets, ambient OT temperature. So that's how try to prevent the hypothermia manage. Then coming to the extubation part, sir. Since these people when you have in the difficult intubation, sir, it's always what you're supposed to do is make sure the patient is fully awake. Then try to extubate over a airway exchanger catheter or FOB, sir. Then sir, do even recruitment of lung also. And try to supplement with oxygen, like perioxygen and preoxygen should be adequate also.
Excellent, very good. So you have made a very good presentation for a very good theory question. Okay, if your question is how do you manage a post-burn contracture neck, say of severe degree with a fixed flexion deformity of the neck, then whatever you have written is completely acceptable, and it's a detailed, well evaluated presentation. But in the practical exam, when you have a case like this, your plan and your treatment modalities that you offer all should be in relationship or concerning the particular type of case that you get. Okay. Now, what Arun has described is a grade 3 or a third degree contracture of the neck, where the neck is in a fixed flexion deformity, lip is everted, mouth opening is restricted. So, your plan should always first enumerate what are all the difficulties. Here, you cannot position the head like a normal sniffing position with the extension at the occipital joint and deflection at the cervical cannot be done in these cases, number one. So first thing, if you want to give GA, you cannot go for regular IV induction or inhalation induction and make the patient unconscious, give a relaxant, put your scope and intubate. That is not at all possible in these cases. That should be first well impressed to the examiner. So what are the other options is, two things you must make sure, whether you will be able to do mask ventilation, because with this being an anticipated difficult airway, the wordings can't ventilate, can't intubate, resulting in respiratory failure. That is the most dangerous thing that can happen to the patient. So you must mention those words in your answer, both in the practical exam as well as in the theory exam. So you can write in the first line, management of this anticipated difficult airway. I will keep in the back of my mind not to land up in a situation of can't ventilate, can't intubate. Okay. So first thing, when you have this patient with a fixed flexion deformity, you cannot apply the mask properly and allow him to ventilate. As long as he is breathing spontaneously, gas exchange will take place. But if you plan to paralyze the patient and stop his respiration, you are not in a position to ventilate the lungs at all in these patients. So that is the most difficult thing that can happen. So unless you are able to mask ventilate, doing anything else to make the patient unconscious is always a risky thing. So what you have to do is your plan 5 should come as a plan 1. Okay. Tumescent is, you said only for a small limited contracture, plan 1 starting with tumescent will not give a good impression about the answer that you are giving, because this contracture is very severe. You are not dealing with a case given to you in your clinical examination. What type of case is given? It is grade 3 contracture with a fixed flexion deformity, inability to look up, lip everted, all these things is there. So saying there as a plan 1 as a tumescent for release of a small contracture is a theoretical answer, but you have to deal with the practical problem of the case given to you in the exam. Okay, so that is a grade 3 exam. There you cannot say tumescent as the first answer and release the whole thing. So the examiners always expect you to say about fiber optic first. Okay, that is the reason why I told Arun about the measurement of maxillopharyngeal angle also, to assess even pre-procedural way to assess the degree of difficulty you may have even with fiber optic also. Okay, so that is what you have to first say. So awake fiber optic intubation will be the safest option that you can do. And whether to do this in the awake position or asleep position is the next question. Okay, if you want to, all patients, you cannot do awake fiber optic intubation, like for example, small kids or the same 25-year-old fellow, because of previous treatment and other things, he has gone into a psychological depression and he is not cooperative. He says, no. As soon as you start putting local anesthetic into the nose and mouth, he starts retching and vomiting and says, no, I don't want surgery, let me go away. So you can't leave that person like that. So uncooperative adult also you have to. So imagine this same patient with a fixed flexion, when you try to put, even in spite of all the counseling, if he says I am not interested in surgery, leave me alone, then you have to go for only a sleep intubation. You have to convince him saying that, okay, we will make you sleep. we'll take care of your airway without any kind of discomfort for you and go for that. So these are the two things first you have to describe. One is awake fiber optic intubation, second is asleep fiber optic intubation. The second thing is, and all the cases, first you must mention about the adequacy of mouth opening and the patency of the nostrils and the nares. These two things should be mentioned. Then only you can plan accordingly. If the nostrils are patent, no contracture or the ala and all those areas, then you can plan for a awake nasal fiber optic intubation. If the mouth opening is adequate in spite of the flexion, some people may have a good mouth opening of 2 to 3. In that case, your video laryngoscope or an LMA insertion may be possible. That's why that will come as the second option. Then the third and fourth option, third option will be to have a good talk with the surgeon, get his consent and get his cooperation and prepare everything, and either under local infiltration or under mild small doses of ketamine, release the neck contracture adequate for achieving adequate extension to put in your scope and then visualize the glottis and intubate and proceed. That is the third option. And the last option will be a fiber optic, tumescent infiltration and excision, which can be, I have done about 90 cases without intubation in my experience, without any complications, complete release of huge scars. If you see those patients, you will be surprised whether they can be managed like that, but we have done that practically. Unfortunately, we didn't maintain any record or publish the whole thing. That was the foolish thing that I did. So it is totally possible because it is only a superficial contracture, not involving any deeper structures. And the advantage of releasing it under tumescent is you can assess the extent of release. You can ask the patient to look up because he is conscious or mildly sedated. They can always cooperate and you can assess the degree of release, and then the surgeon can plan his covering of the raw area according to the extent of release he achieves. Okay, so this will be a better order than what you have described. So don't go for tumescent as a first option. So first option should always be awake fiber optic intubation. Either if the patient uncooperative, asleep fiber optic intubation. The second will be the mouth opening is good, you can try for a video laryngoscope. Of course, there are several varieties of video laryngoscope. And topical anesthesia, you can try the video laryngoscope and push the tube in. Or you can use an LMA through which you can try to intubate the patient. The third will be release of contracture with a short anesthesia, either mask holding or by ketamine, and achieving adequate extension and then going for a regular laryngoscopy and intubation. And the last one will be tumescent local anesthesia. But in my experience, again, we have managed a lot of these cases with awake blind nasal intubation also. Even though the present day examiners, I don't know what is their experience in managing these cases. They always say it may be difficult to do a blind nasal intubation, but in my experience, we have successfully intubated many difficult contractures under awake blind nasal intubation also, listening to the respiratory noise. But unfortunately, with the present set of examiners, you have to dance to their tunes and answer what they like, and most of them watching the several videos in the PG online classes, I find that many examiners don't like saying that you can do awake blind nasal intubation. Seem to be probably they have not done, or nobody is trained in the art of that. They seem to not accept that as a part of the answer. But in my career, I have seen it's one of the very useful methods, especially both contraction neck and TM joint ankylosis. I have never used a fiber optic for all these cases because it was not available in our days. So we were forced to do only blind nasal intubation, and we have been successfully doing that without any difficulty and with utmost comfort of the patient. So I am not including that as a part of the plan for managing the airway. So apart from that, these 4 plans will be more than sufficient, and all other points what you have mentioned about the tolerance to opioids, the hypothermia, the blood loss, the difficulty in placing the monitors, all these things are quite valid. And at the end of the procedure, you said fiber optic extubation over a fiber optic. I don't understand how can you do that. If you pass a fiber optic scope over the tube into the tube, and then how can you pull out the tube? You have to remove both the scope and the tube will work together, isn't it? So you can put an airway exchanger, but not a fibroscope. You can just inspect through the fibroscope, but extubation with the fibroscope is not a correct answer, because once you put the scope into the endotracheal tube, you have to remove it along with that. It will act like a fillet only. Okay. So, and the other thing they ask about or talk about is the maintenance of oxygenation during. That is an important part that is being recommended in the Difficult Airway Society guidelines. Even when you are doing awake fiber optic under topical anesthesia, whatever method, either by spray and go or by a specific blockage of all the areas by packing and other things, the oxygenation should always be maintained. That is another important guideline that they insist on. So how to maintain the oxygenation when you while doing fiber optic or your video laryngoscope or whatever you try, how are you going to maintain the oxygen level? Patient will be breathing spontaneously, but supposing he holds the breath or some spasm occurs, how are you going to maintain the oxygenation? So they say either you start nasal cannula on the other side of the nostril, the other nostril which is free, you always put in a catheter and give a high flow oxygen. Or nowadays Thrive is available. So they say when you do video laryngoscopy, you can use both the nostrils and use the Thrive machine to give a high flow oxygen. Okay, that is being recommended as a part of the treatment or maintaining the oxygenation through this throughout the period of managing the difficulty airway in these patients. Okay. So otherwise, I think you have covered all these points.